I think we have plenty of abstracts to discuss. So let's start. So I have divided the sessions into two parts, early breast cancer and advanced breast cancer, because as I said, there are too many things to discuss. So first part of the abstracts that we are trying to identify actually which are the patients who do not benefit from chemotherapy, and a lot of work has been done in the last decade. Now, I think the most important, I think, abstract I feel is the WSG ADAPT trial that was presented. So the question to the panelist is that, do you use short-term preoperative hormone therapy in your practice? Does anyone use?
For early breast?
Yeah, for early, this is all for early breast cancer. Do you use short-term preoperative hormone therapy in your practice?
No, not it.
No.
Ashish, only in a few very select, I had a 78 years old fungating breast mass, strong ER positive, but non-metastatic. In that lady I have used
But
for
then
3 weeks.
do you use it the way they have used it? Like, do you assess Ki-67 after the preoperative therapy? No. So, do you think the results of this WSG ADAPT trial, will you change your practice based on the trial that has been presented?
So, as confirmed for the early breast that we talked, the PALAS was a negative trial. It didn't help the early breast in the
We are
adjuvant.
talking about the WSG ADAPT trial, where they used preoperative endocrine therapy for 3 weeks, and then the patients were randomized to giving chemotherapy versus continuing with the endocrine therapy.
So, at the moment, no.
Maybe we have to see the long-term results. I think this would be one of the good factors to differentiate between the chemotherapy required people and not required.
So,
maybe,
they showed that those patients who have low Ki-67 post
yes.
less than 10% post the endocrine therapy period, they could be if their recurrence score is between 0 to 25, you could probably omit chemotherapy in this group of patients.
Requires long-term follow-up, definitely, but we can consider.
So anybody from the audience has a different opinion? Do you want to use this in your practice? Vani?
I think so. In the age group of 16 to 20, in the age group, premenopausal age group with 16 to 25 score, I think so. This would be an interesting strategy, and I mean, I'm not using it though, but it definitely is a discussion. If the patient can go for oncotype DX, and if the patient can go for oncotype DX, it could be considered.
Okay.
A lot of parameters are involved, a lot of things that we don't do in regular practice. Oncotype, how many of our patients can afford Oncotype DX, that is first. Second is how many of them will be willing to do, there was a trial wherein they used to do intermediate biopsies again to see for the Ki-67 index. So all of these difficulties do present in normal, in community or clinical practice. So I think adjuvant hormone therapy would not currently be my clinical practice changing trial.
Okay.
Ashish, I think the biggest flaw here is that you're not going to rebiopsy her again. E67 is something that you evaluate with a rebiopsy. Then only you will know whether there's a response or not.
Yes, absolutely. If you have to follow, you have to follow as per the protocol.
I think that is where the problem comes.
Okay.
So, Ashish, one more point.
Yeah.
Is that if we follow this practice, we need to do the oncotype score, and is it before starting?
That was done baseline.
Baseline.
Yes.
So it takes about 3 to 4 weeks. So for 3 to 4 weeks, patient will be without treatment.
So I think, no, you start the endocrine therapy after that. So when you do the initial biopsy, you send the RS score, you start the endocrine therapy. By the time in 3 weeks time you finish the preoperative endocrine therapy, you get the RS score result.
Okay.
And then you decide. Right. So I personally find this as quite an interesting strategy actually. Now the question to the panelists is that, like, I agree that very few of us are able to do RS score in our day-to-day practice due to the finances. Are you willing to use this as a sole criteria to decide whether to give a patient chemotherapy or not? Let's say you are not doing RS score, you give preoperative endocrine therapy, your patient shows a good response to the preoperative endocrine therapy with a good drop in the Ki-67. Are you willing to forego chemotherapy in such group of patients?
It's very tricky question. I don't think we'll be forgoing chemotherapy if other parameters or other things that we usually see in our clinical practice like age, comorbidities, and all of those are in favor of chemotherapy, we should definitely be giving chemotherapy not based on this. We would require further trials to confirm this.
I think for subset of the patient who are elderly patients or something like that, we can. But I think at this moment, it's difficult, to take a pinch of salt just to forgive chemotherapy for the
I
patients.
think most of us are not very comfortable with this idea at this point of time.
While Ki-16 alone is very difficult, sir. I think we can consider some lymph node and T3 stages, then based on them we can.
Right.
But
Are
not-
there any pathologists
Ki-16
in the
alone is very
audience? Is there anybody in the pathologist who's from the audience? Okay. Unfortunately, we don't have any pathologist with us, but reporting of Ki-67 is also a very problematic and tricky thing.
So coming to this point, this idea is not new, sir. This is there since 12 to 15 years probably. When we were residents, that time also we've gone through a trial wherein every 2 months they do a Ki-67 index. There was a trial, I am not remembering the name. They used to check the Ki-67 index, and a median of 4 to 6 months of neoadjuvant NACT were tried in that. So the idea and concept is not new, and it's there since 12 to 15 years, and then we've not adopted that means that there's some flaw to it.
So I have one comment for this complicated decisions these days. So when I was resident in 2014, so we used to use Predict Online. So it's an easy way to make a decision that how much chemotherapy or third generation chemotherapy is going to add the benefit. So if it is less than 3% or 1%, then we have a discussion with we used to have a discussion with the patient and their relatives, and some of them, they used to say, no, we don't want chemotherapy. So that was one way of going it. Subsequently, Oncotype DX came, and then Mamaprint, and then we have our own CanAssist. A certain situation, even CanAssist also is not, is there, and it is time consuming. So recently I had one patient of mucinous variant of the CA breast, early breast cancer. Size was around 3.5 centimeter, it was grade 1. And I just utilized the Predict Online, and the benefit was just 1%. The patient was quite educated, and she said, no, I don't want chemotherapy. So such kind of things, yes, they do matter, and with such kind of knowledge and the sea of information, we are forgetting the basics, but we have learned around 1.5 decades back.
Okay. So I think this, I have specific put, I think there is an excellent editorial by Mitch Dossett on issues in the challenging Ki-67, like somebody can have a significant drop, but still their values are more than 10%. Whereas somebody may be less than 10%, but their Ki-67 is rising. So there are some challenges, a lot of technical issues, even in the trial that they mentioned. There was not a good correlation between the local and the central lab with regards to the Ki-67 values. And the IKWG guidelines have been published, which again requires a lot of quality control in order to report Ki-67. So that's why I think probably it's difficult to kind of adapt this trial. So let's move on. We have another set of trials to discuss in search of the best adjuvant endocrine therapy for ER-positive breast cancer. And as we have gone through a lot of abstracts, so the question to the panelists is that, do you use ovarian function suppression in your practice? If you use, which are the patients in whom do you recommend? And do you periodically monitor patients' menopausal status while they are on therapy?
Yes, definitely we are doing ovarian suppression for patients who are younger than 40 years. They have a high-grade tumor, their LVI is positive, or they have a high Ki-67 score. The tumor size is more than 4 centimeters. So definitely those subgroup of the patients are definitely that we recommend that you should go for an OFS.
Okay, anybody has a difference of opinion? So the SOFT trial has clearly shown a lot of benefit in terms of the disease-free survival, and the latest publication published in JCO also shows some overall survival benefit. So it should be considered in those patients who are high risk, grade 3 T2 and age less than 35 years. Now the EBCT and meta-analysis also we have discussed. Now how do you explain? We also discussed the Stockholm trial. I think Shruti presented that trial. So how do you explain the differences between the Stockholm trial and the SOFT trial? In the Stockholm trial, there was increased risk from the addition of tamoxifen to goserelin in genomic high-risk patients. So how do you really explain? One trial is telling you that they are at a higher risk of recurrence if you give a combination. Other trials are telling you that you should give a combination. So how do you reconcile with that?
I think there is only one trial which showed something the goserelin and tamoxifen will increases the something, but remaining all trials are different. But again, that trial contains 4 arms. Actually, there is no endocrine therapy also in one of the arms. Again, they have given the tamoxifen dosage 40 mg in this trial, but other trials only 20 mg. So I think we can't cross compare between these trials, and we can't compare conclusion that the goserelin and tamoxifen will harmful to the patient.
But again, ZIP trial also didn't show any benefit of the combination.
So
So,
because
there are
there is-
some trials
yes.
which have not shown really the benefit.
Yes, correct.
So as
So
the
it's,
paper,
I mean, we have been
she had-
trying to find out this solution for maybe more than 30 years now. OFS trials have been going on for that long, and still we are struggling to find an answer.
Yeah, only individualized therapies are nowadays the people they are
So
preferring.
the
That's
paper that was presented earlier, that shows the agonist effect of tamoxifen was definitely counteracted by the estrogen depleting effect of goserelin. So probably in low risk patient, this tamoxifen held the recurrences for a longer period of time, and goserelin helped the high risk, genomically high risk patient for a near recurrences. So basically this was the rationale why we added tamoxifen to goserelin and how the design was tried.
Okay. So for those who use ovarian function suppression, do you face any compliance issues? How many of your patients continue? Indu, your take, in your practice, do you use it, and do you find that people are willing to continue it for 5 years as recommended in the soft trial?
No, there are compliance issues, definitely. But I do advise this strategy to my patients. But there are definitely compliance issues because it's a long-term treatment, and there is definitely compliance issue.
So Vani, what has been your experience in Tata?
Face that much of a compliance issue. Our patients do continue. Probably cost is the only factor which sometimes comes in, and the repeated injections. And since we are doing GnRH as such in a 3-monthly now, so it's actually the compliance is okay. We have not
So
had much.
these are Western data what I have showed you here, and almost 25 to 50% of the patient where affordability is not an issue. I think the patients are stopping primarily because of the side effects of the therapy.
Yeah.
I think
So
it just
I
needs
have a
good
lot
counseling
of
actually.
patients who have issues with skin changes, flushing, emotional imbalances. I have at least 20 to 30% of the patients, though it may be a small cohort, but yes, these I have stopped in 2 patients for these problems.
And do you face these problems in patients who are on, say, letrozole alone?
No, very unlikely. So I have had 2 patients who were already on antipsychotic medicines. They faced challenges with letrozole. I had to change them on tamoxifen. But overall, on letrozole, I don't face
So actually, if you look at the Western data from many of the even adjuvant trials, anastrozole discontinuation rates are as high as 20%.
Yes.
So that's a little bit surprising actually, which I think in India we don't see that in clinical practice, that so many patients are discontinuing their
I'll
tamoxifen or
disagree with you,
letrozole.
Ashish, because we don't ask. Because especially postmenopausal patient who are on, AI inhibitors, lot of them will come with joint pain and all, but we don't
No,
have so
they
much
do
of
come.
time.
I'm not denying that they don't have side effects.
No,
What
but
I'm
then-
saying is that they don't discontinue. That's what has been my experience.
There where the concept philosophical differences and cultural differences do come. हमारी महिलाएं बहुत सहनशील होती है, and this is where
I think that
we
may be
don't
partly the
appreciate
reason,
this, and
yes.
such kind of a parameters we should study and publish it also.
Right.
Because this is not a difference. We get the patients around 15 to 20% do have severe symptoms, and hardly anyone they drop off from the medication. Hardly anyone. They would like to continue with the therapy.
So right, I think that's a very valid point,
Can I
Amol.
make a comment on that, please? Can I make
Yes, please.
So while I agree to him, but a lot of patients won't tell you that they have stopped taking the medication also. Please know that. No, they will come.
Yeah, maybe
They genuinely, they'll come to the clinic, they'll come with their husband or sons, and they will not accept they haven't taken medication. And you can know that by saying how many joint, if you ask an open question, ऐसे बिल्कुल नहीं हो रहा, think carefully कि वो non-compliance है, यहाँ पे तो data है कि छोड़ दिया. वहाँ पे पता ही नहीं चलता.
So, yeah, Nitesh, you are right. I mean, of course, we are not monitoring PRO. We are not really checking compliance in our day-to-day practice. Yeah, Vani.
Compliance issue, I think it is those who take aromatase inhibitors with ovarian suppression who have much more severe symptoms as compared to tamoxifen with ovarian suppression.
Agreed.
But I would like to know from the panel also how many patients do you just switch to aromatase inhibitors with ovarian suppression? Premenopausal women, how many of them do you put onto aromatase inhibitors with ovarian suppression? See, that is where the difference comes in because quite a few of our patients continue TAM plus ovarian suppression because that has also shown good benefit. But if you really move on to high-risk patients and put them onto aromatase inhibitors with ovarian suppression, the side effects and toxicity is much more. So they get those compliance issues, I think, primarily come into that subset. So that is where the difference comes in.
But Vani, if a patient is there between 45 for that perimenopausal age group and you want to make the switch, there is a compliance issue comes. At least in my clinical experience.
So,
I'm not sure about the age group. I think it's more to do with the AI with ovarian suppression compared to TAM with ovarian suppression. And even the trials have shown the same thing.
okay, so I think
common
let's move on. We have a lot of things to discuss actually. Okay. So, anybody has any experience of using this clinical utility index that have been presented today, the breast cancer index or a 70 gene signature to decide which patient should receive ovarian function suppression? Any particular comments from anyone with regards to this? Because this is quite actually interesting that high genomic risk patients, they derive more benefit with goserelin as compared to tamoxifen, and low genomic risk, they derive more benefit with tamoxifen. So I think this is something that needs more exploration in clinical trials. Again, this has been discussed, so I think let's skip this now. Just a final question, does anyone think OFS alone is an option in some patients?
No.
Like 2 years, they have shown in the Stockholm trial, just 2 years of goserelin alone and nothing else. And patients are doing fine actually, quite a bit. Yeah, yes.
You asked a previous question about the genomic index.
Yes.
I'd like to hear what Dr. Bardia has to say because he would have more experience with this.
Yeah, thank you. I can comment on BCI. Actually, it was developed at MGH. Dennis Segroy was the pathologist who developed breast cancer index. So we have some experience. In general, the use of BCI is to evaluate where someone needs extended endocrine therapy versus not. And I think it's now in the NCCN guidelines as well. So we do use BCI to decide if a patient needs 10 years versus 5 years of endocrine therapy. So far, we've not used it to decide who needs ovarian suppression. And it's a bit embarrassing because it was from our institution, but it's not something that we use.
Okay. So, okay, now the next question is obviously coming to the optimal duration of adjuvant endocrine therapy. There have been trials right from 2 years, 5 years, 10 years, and as long as up to 15 years. So, we had two abstracts to discuss with regards to the duration of adjuvant endocrine therapy. So, maybe Dr. Bardi, again coming back to you, in your practice, which are the patients whom you recommend extended duration hormone therapy?
Yeah, in general, extended duration hormone therapy is for a patient who is tolerating endocrine therapy well. So it kind of self-declares itself. If a patient is really doing well on endocrine therapy, they're not having much side effects, close to end of 5 years, you have a discussion. There are some patients who would be like, I just want to continue, I don't want to stop. There are others who would be like, I'm done, can we stop the therapy at this time? I feel comfortable if a patient has low-risk disease to stop at 5 years. Intermediate, it's a discussion. For high-risk patients, we generally try to get at least 7 years, if not 10 years of endocrine therapy.
Okay. Yeah,
so I agree with him. And I'm a bit hesitant to stop the treatment after 5 years, especially if the patient has high-risk features, heavy nodal burden, and the tumor size more than 5 centimeter. So I usually discuss with the patient that we may extend it for more than 5 years. Then of course we have to check the toxicity. The most common toxicity is osteoporosis. So we have to keep a watch on that. And most of the patients are willing to continue.
Okay. So does anyone use the CTS5 calculator? Because I think one of the challenges that we have is that these gene indexes that have been discussed we don't have access to them, practically zero. So does anybody use the CTS5 calculator to determine the need for extended duration hormone therapy? No. Okay. So I think these studies have been discussed and there is definitely a subgroup of patients who benefit with extended duration therapy. Whenever possible, we should try and kind of do these tests available, but otherwise I think one should use the CTS5 calculator. Now one question, Dr. Aditya Bardia, again I have one question for you. I have a patient who is 18 node positive out of 45, okay. Non-metastatic, confirmed by PET scan, on 10-year follow-up. Patient has received extended duration up to 10 years of hormone therapy. Would you be willing to stop the endocrine therapy at 10 years or would you continue up to 15 years in such patient?
Yeah, no, good question. We don't have much data to suggest that 15 is not necessarily better than 10. So it's a data-free zone. I think it's a discussion with patient. There are some who would be willing to continue endocrine therapy. So if there's a high-risk patient, I would actually continue beyond 10 years as well, with the understanding that we don't have data, but because we don't have data to suggest it's not beneficial either, I would feel comfortable doing that.
Yeah, actually I'm a bit scared to kind of stop the endocrine therapy with that high nodal burden because the feel is that probably the patient would relapse soon. Yeah, yes, Amol.
Exactly the same thing. When we wrote that correspondence in NEGM for combined analysis of soft and text, and then I realized that the Dr. Meredith is not a clinician, she is a mathematician at your institute. And just I asked, can you provide us the data for the node positive disease? So when we talk about all this data and when we come to our end of surveys, we have so many patients with the node positive, and in the combined analysis, we don't know how many nodes are there. And that's how, so we should have our own, consensus recommendations, or we discuss more how to tackle our premenopausal patients. That is one. And second is whether it is 7 years or 10 years or 15 years, like your practice is not comfortable even stopping at 10 years. So in such scenario, at your institute, how do you manage such cases? You might get one or odd case without the discussion. What is your conviction, whether you to stop or you should continue?
For a high-risk patient, my conviction is to continue. As long as we don't have insurance issues and as long as patient feels comfortable, as long as you're not having a lot of osteoporosis. So in terms of risk-benefit, if the risk is not high, I would feel comfortable continuing beyond 10 years. I think in the future, we might be using ctDNA in this setting. So you can monitor tumor DNA, and if a patient is not having detectable tumor DNA, you just do surveillance, and when you see tumor DNA comes up, you can add it again. But I think that's more in the future.
Great.
Okay. So Rohit, one question for you. This is sound kind of outrageous question, but are there any patients in whom you can omit endocrine therapy?
Not really.
No endocrine therapy at all.
Not really. HR positive.
Because if you look at this Stockholm trial and the results from the MIDAC trial, there seems to be a subgroup actually where they are doing very well even without endocrine therapy. So why to kind of expose them? So I think probably we need to have more research on this, that de-escalation, and I think that's going on just now at this point of time to identify whether we can de-escalate the endocrine therapy also.
Ultra low risk.
The ultra low
risk, the people they'll say that one.
The ultra low subgroup of the patient.
Correct, correct.
We
Yes.
showed that they had no risk.
Yes,
No
Dr.
cancer. For DCIS also, we want to give hormonal therapy. So why to omit in the invasive cancer?
Yeah, I know, it sounds counterintuitive. So let's move on to the further discussion on adjuvant CDK4 inhibition. We have heard through the trials, I think ad nauseum, about the different trials that have been run. What is your take? Maybe Ritu, why do you think that one trial succeeded while other didn't? Only the one trial is showing positive results.
To be honest, I don't know the answer, but it is, I mean, it could be statistics, the data collection, and the biology of the disease.
The reason,
Yeah, Dr. Manisha?
Yeah, the reason they had showed that because we are taking this drug only 3 weeks and giving a rest of 1 week, and for Abima we are taking throughout the month. So that is probably a reason where the cell cycle is, it's circulating all the time and the drugs is activating. So that was probably one of the reasons which they showed could be an answer why PALAS didn't work and Monarchy had a response in adjuvant setup.
Actually, the PALAS trial has entered multiple categories actually. They have taken the low risk and high risk also. But compared to this, again, Monarch E, all the trials, they chosen only high risk population. So with that, I think only this PALA trial has only 30% or the high risk. So with that, I think there is a results are skewed towards one area. So we can't just cross compare these two trials with this one. So ultimately, the Monarch is specifically meant for high risk population.
So now the question to you is that on Monday morning when you go, you have a generic palbociclib available now. If you have a patient who comes to you, he cannot afford abemaciclib, what will you do?
Yes,
will you offer palbociclib?
Maybe I think we have to just think, again we have to read in between lines and ultimately...
And perhaps the affinity for CDK4, which was more for abema, could be a second possible cause. A very high affinity for CDK4, 16 times more as compared, 11 times more as compared to the other CDK inhibitors. So these were the two possible explanations that Monarchy worked, otherwise PALAS didn't. But we need to explore more, and we have to have more patient, more data, and then to really say that really abema works and palbo doesn't work in an adjuvant setup.
Okay.
Excuse me, Ashish.
Yeah, hi.
Hi. So I think you are, actually presuming that all of us would consider a CDK4/6 as du jour with aromatase inhibitors on a Monday morning in high-risk patients, which is to say that anybody who is not using that is not practicing scientific medicine. I would argue on the contrary, that we are exposing our patients to a drug which has not seen OS advantage. So what's your thought on that? And I would like to hear Dr. Bardia, who seems to be the high priest on CDK4/6, on this particular issue, and also the fact that some of these drugs are not a walk in the park. And what do you do when these patients relapse, eventually, if they do? So those are my questions for you, Dr. Bardia.
And maybe you can start, would love to hear from others as well. In terms of the use of CDK4/6, I think based on Monarchy for a high-risk patient, it's very reasonable to consider. But you have to talk about the side effects as well, which includes diarrhea, which includes the risk of venous thromboembolism. So in general, we tend to use it with AI, not with tamoxifen because of that reason. And then financial toxicity is definitely another consideration. In terms of overall survival, this is ER-positive disease. While high risk, I think it'll take a while for us to see improvement in overall survival because it's not TNBC. So we just need longer follow-up. But overall survival is important, and I think that was the reason why the FDA in particular only approved abemaciclib for patients who had Ki-67 more than 20%, lymph node positive and high-risk features, because in less than 20% they saw a slightly detrimental OS benefit, so detrimental not in favor of abemaciclib. So there was concern that abemaciclib actually might reduce survival. So that's why they did not approve, because they wanted longer follow-up in that setting. We definitely need more follow-up. What was good to see at San Antonio last month was that at least we continue to see a separation of the curves in terms of disease-free survival. So that was very reassuring that with abemaciclib, maybe you can cure some patients. I think that is the biggest question in the field. Are we just delaying metastatic disease, or actually are we curing patients? And I think our goal is cure. And so I think the problem of what to do at the time of disease recurrence is a good one, but I would rather cure patients and have that problem that there might be some who have disease recurrence and what to do in that setting. In that setting, then you have other drugs, newer agents, newer ER degraders, antibody drug conjugates. So I think that's a good problem to have. As long as we are curing patients, I would feel very comfortable with this drug.
Okay. So now, Dr. Aditya, this question is again back to you. If your patient fits the criteria for abemaciclib, and if it is BRCA positive, what would you offer to this patient? Would you offer olaparib adjuvant, or would you offer abemaciclib?
Yeah, it's a very good question. When Monarchy was presented at the virtual ESMO about 2 years ago, this question had come up. And I think in the past 2 years, we still don't have the answer to this question, because both are very reasonable. The ones who would favor olaparib would say that this is a therapy that's tailored to patients who have BRCA mutations. So in this setting, that's what we should use. The ones who would favor CDK4/6 would say that if we look at Olympia, majority of the benefit was in the TNBC setting. It was the TNBC subgroup that drove the overall survival benefit. And so we should use abemaciclib. I think for a really, really high-risk patient, I would consider both. You might do 1 year of olaparib, and then after that, you can do 2 years of abemaciclib. We were discussing in ER-positive disease, we can do extended endocrine therapy. So that's the idea. You start with olaparib, and then in the second year, you can do 2 years of abemaciclib, as long as cost and patient compliance is not an issue.
I think so. In the monarchy, the enrollment post-surgery was actually up to 16 months. So you could probably go ahead with olaparib, complete olaparib in a high risk, as Dr. Bardia said.
Okay. So everolimus, I think we will skip this. Now this question is, Indu, can you take this? Would you offer adjuvant S1 in your patients with ER-positive breast cancer if they are unable to go for abemaciclib?
Option to my patients so far.
So there is one trial published by the Japanese group actually where they have used adjuvant S1 plus endocrine therapy, same as abemaciclib actually. And as you can see here, almost like 60% of the patients had received either neoadjuvant or adjuvant chemotherapy, and they showed improvement in the disease-free survival. So probably, I think this is thought-provoking. I know that there is no evidence to practice this on a day-to-day basis, but probably in your high-risk patient, this is something that one could think of, or maybe we need to do more trials to kind of find this. Pardon? This is evidence. Obviously, this is evidence. What I am saying is that to practice as a standard of care, I am for this. In fact, I would say that those who are high risk, those who are not able to go for abemaciclib, this is something we should consider. Absolutely, absolutely. So I am also for it. I am not saying that we should discard this. So probably like the way we are doing for HER2/neu, we are doing for triple negative, we are giving adjuvant capecitabine. This is one window actually for S1 in patients who are hormone receptor positive. So probably interesting concept I would
follow
say.
करेंगे, east को नहीं. That is the mantra here.
You know, if time permits, I'll just discuss, since we are in adjuvant amoeba. I have an elderly patient. I discussed both high risk node positive, ER positive, and cost is not an issue. I discussed the pros, cons, educated family and the patient. Because of the side effect, they said we'll go for chemo. So I gave her weekly Pacli and low dose chemotherapy. So in that patient group, I would definitely think of S1.
Right. Okay. So now the one quick question about the bone health. What is the experience of the panel? Do you really see such high incidence of bone fracture in your patients who are on adjuvant endocrine therapy?
Rarely. It's very rare.
So anybody from the audience has this kind of experience? We do bone mineral density, we do DEXA scan periodically while the patients are on. We have actually not seen such high incidence. But of course, we would give derazumab for the benefits that are there. Now for elderly patients, again, a quick take. What would you choose, Dr. Sadashiv?
It's a simple one, sir. Always we'll give the only hormonal therapy first. I think we
So
discussed.
for your patients who are beyond 70 years of age, if they are a little bit high risk, would you choose chemotherapy or would you choose hormone therapy? Considering the discontinuation rates that they have showed.
Preferably we'll use only hormonal therapy because they are very tolerable, they can continue therapy. Chemotherapy, most of them, they will not complete the planned chemotherapy cycles.
So see, 70 is
Of
the
course,
age which is not really very elderly in my view. Today, for multiple myeloma, you recommend transplant to that patient. So why to kind of forego chemotherapy?
If the high
in this
risk
group
is
of
there,
patients?
definitely we can consider chemo followed by the hormonal therapy.
Okay, so I think we need to individualize. Let's move on. We have another 20 minutes with us. So let's move on to the metastatic breast cancer. A lot of abstracts have been discussed. Any quick take, Dr. Vijay? Any quick take on FES PET?
Yes. So FES seems to be a promising this thing. I mean, in bone biopsies where, in ER positive where bone biopsies might not be very feasible at times, I think so FES could be the answer. Also, sometimes in lobular carcinomas where FDG PET might not be giving answers.
So I personally feel this is a very interesting kind of investigation that is available, because many a times when you are really worried that whether the patient has, say for example, high nodal burden and they have PET scan doesn't show very high uptake on FDG, but FES probably may kind of tell us that the patient has a metastatic disease. Okay, now for patients who are on visceral crisis, what is your choice of? Rohit, what is your choice of chemotherapy, choice of treatment for patients who are in visceral crisis?
So the definition of true visceral crisis is sort of shrinking. So for example, bone marrow involvement or lymphangitis, probably it is a single agent, weekly paclitaxel, something like that. And I would like to switch to hormonal therapy as soon as possible with a CDK4/6 inhibitor.
So I think that's one of my issues with this trial, right choice. I think if I get it correctly, they randomized the patients to chemotherapy, but that arm didn't receive any further hormone therapy. Is my understanding correct? So probably this is something that we would not do, because I think in our practice what we would do is that as soon as we finish the chemotherapy, we'll put the patient back on some sort of a hormone therapy. So, so would you consider ribociclib in such patients who have aggressive disease, or would you consider chemotherapy? Udip?
So what I've seen is in Ki-67, less than 20 patients, usually they respond very well to ribociclib. Even in a visceral crisis, the response rates are very good. But in a Ki-67 which is higher, probably with a very high burden disease, I would go ahead with the chemotherapy first and then continue on hormone therapy.
Okay.
The goal of therapy here is, most of us, I think, as a teaching, what we do is visceral crisis. We'll try to decrease the tumor burden early. We'll get the rapid response. But with the invention of the CDK inhibitors with aromatase inhibitor, definitely we are able to get the early response and with rapid response. And response rate also almost equivalent to this chemotherapy. So still, I think if the patient can afford, you can go on something CDK inhibitors and AI instead of chemotherapy.
Okay. Now, does anyone use, do you decide between the choice of chemotherapy and endocrine therapy based on circulating tumor cells? I think Dr. Aditya, you can take this probably, because none of us would have really an experience in this. So what do you recommend?
Yeah, we don't use it routinely in clinical practice. We have experience with CTC. Some of the studies were done in the US, but it's not something that's used in clinical practice. I think that something that would likely be used in clinical practice in the future is ctDNA. I think the PADA-1 study was a very interesting study, because monitoring ctDNA, and when you see rise in ctDNA switching therapy at that time, seems to at least improve progression-free survival. We'll have to see if it improves overall survival. But I think that probably is a strategy that might come in the future.
Okay. So I think this STICK trial, they used a very interesting hypothesis where clinically low but CTC high, they showed benefit with chemotherapy. Whereas those who were clinically high but CTC low, they showed that chemotherapy and adjuvant therapy, endocrine therapy, both are equally efficacious. Moving on, if the patient progresses on CDK4/6 inhibitor, what will be your choice of therapy? Indu?
So, I would like to definitely biopsy the patient just to see the status of hormone receptors. And if it depends on the symptoms, whether the patient has visceral crisis or the site of metastasis, I would like to see. I would like to explore the option of maybe depending on, so I would like to see, I would like to study the tumor further to see the mechanism of resistance, and depending on that I would like to choose the therapy. So this is what would be my strategy.
So say for example, patient has got say AKT alteration, what would you use Indu?
Can you please repeat?
If the patient has got a AKT alteration, what would you use in such patients?
So, as I said, like it depends on the symptoms. If the patient has visceral crisis, I would like to go for chemotherapy first. And definitely second line treatment may be alpelisib.
Okay. Dr. Aditya, this is for you. Do you use everolimus now in your clinical practice, particularly since the availability of alpelisib so widely in US? Is there any group of patients where you use everolimus?
Yeah, absolutely, because in the metastatic setting, it's a matter of using drugs sequentially. So even if you use alpelisib in the second line setting for PIK3CA mutant breast cancer, you can use everolimus in the third line setting. And now with the use of mouthwash, usually you don't have so many side effects. And for PI3 kinase wild type, everolimus is a therapy that could even be considered in the second line setting.
Okay, all right.
So we had two contradictory papers again at this presentation. The first was the switching to ribociclib. It worked. As well, the PACE trial didn't work when we switched to, changing the partner with fulvestrant, we used palbociclib, it didn't work. So again, the confusion remains whether, switching to other CDK4/6 works in such group of patients, because they have worked for a couple of years, 2 to 3 years, the patient had been, remained symptom-free. So this is again a question of debate whether we should or we should not, because we have two conflicting paper results come up regarding palbo and ribociclib.
Ma'am, but the incremental benefit in the ribociclib change switch was just 2 months. I mean, though it was like 5 months and versus 2.5 months, how, clinically significant it would be, though statistically significant it was. But with the availability of NGS, if you are looking at the gamut of markers and we are discussing about AKT and downstream pathways, I think so just switching over to fulvestrant in coming times probably might not just be the only thing.
Right. So I think we discussed this. Now this question, I think Dr. Aditya, you raised this. I think we need to raise this. So that if you have given adjuvant abemaciclib to this patient and now the patient progresses, what would be your first line of therapy in patients who have a metastatic disease?
Yeah, this
would you re-challenge them with a CDK4 inhibitor or go on to some other therapy?
Yeah, it's a data-free zone. I think the question would be whether the patient had disease recurrence on adjuvant abema or after adjuvant abema. So there are two scenarios. One is a patient has disease recurrence in the first 2 years on adjuvant abema. That's a subgroup I'll be concerned. It's mostly endocrine resistant disease. Patient had endocrine therapy plus abema and despite that has disease recurrence. So I might actually consider chemotherapy as first line for that patient, at least initially, and in the future you can revisit endocrine-based therapy or one of the newer antibody drug conjugates. If a patient was on endocrine therapy plus abema is stopped, patient remains on endocrine therapy, and then say at the end of 5 years or 6 years, has disease recurrence, that's a different scenario. That's more like a second line setting. In that setting, I would consider fulvestrant plus minus some other drug. If a patient has PIK3CA mutation, you could use alpelisib, you could consider everolimus, but I would still consider endocrine-based therapy in that approach.
Okay. Now, so Dr. Manisha, what is your take on routine monitoring of ESR1 mutation? Do you think we should be doing this as a routine in our practice?
I don't think we should be doing, but really we are tempted by the result of the paper that came, that if we do, we have an early option of changing the CDK4 partner. Just we changed from AI to fulvestrant and the patient had a significant improvement in the PFS. So definitely I think it is a tempting thing we should be prompted to do for the subgroup of the patients who can afford to, undergo these tests.
So if you choose to do it, how frequently will you monitor?
I mean, it's 2 monthly, as per the guidelines, I think it's, when you have started giving endocrine therapy, biopsy it 2 monthly. Sorry, get the ESR testing 2 monthly.
Okay. So, I think we, now...
The idea behind this trial is, I would like to say something. The idea behind this trial is they don't want to change the CDK4 inhibitor. They wanted to change only something like an aromatase inhibitor by switching to another one. Because if one company does the trial, I think they'll want to change only the other aromatase inhibitor. Another, for example, is the CDK inhibitor company, they want to do the study, since they wanted to change this CDK4 inhibitor. So everything is something we have to take it a pinch of salt and we have to dissect each and every result clearly. Then only we can choose therapy based. But based on one trial, one study, we should not change our what madam said, confusion. Yes, definitely it's a confusion.
But with ESR1 mutation, the data is quite convincing
Yes,
that
but
fulvestrant
we
would
need
work
this.
in those group of patients who are ESR1 mutant. Now, what about the newer other SERDs that are coming for breast cancer, elacestrant, imlunestrant, and so on, so many of them who we cannot pronounce properly as yet. So what do you think is their position in the practice?
Let them get launched in India.
Maybe immunotherapy is again, for most of the discussions again will end up with the immunotherapy. So maybe I think again we have to choose the best population who are going to get the maximum benefit out of it. Again.
Okay. So I think I think this is the last question probably. What is the role of immunotherapy? I think Dr. Shona madam presented that study of PACE trial where they showed that in those patients who are progressing, in them addition of avelumab showed improvement in progression-free survival. So this is something would you consider in your patients?
No, I said.
We have data for TNBC, right?
But it's an ER positive tumor, ma'am.
Okay, so I think probably, on an individual case by case basis, if you have out of options, then this is something that I think I would consider. But other than that, obviously not is something that as a routine. Now, coming to the side effects related to abemaciclib, does anybody have an experience of developing a VT or a pulmonary embolism with abemaciclib? Anybody from the panelists can take? Yeah, Udit.
No, not yet currently. So only loose motions or diarrhea in couple of patients, there are around 20%, and no VT as such. Most of the patients have tolerated well. Even 200 doses, single agent 200 doses well tolerated.
Okay. Anybody from the audience has seen DVT pulmonary embolism with abemaciclib? Okay. So I think probably we are doing good there, or maybe we have too less experience with it. It is something that time will tell. Now, how do you manage that? If somebody develops it, how do you manage that? Would you stop abemaciclib or would you continue abemaciclib and give a anticoagulation? And if anticoagulation is to be given, what would you give?
Maybe we don't have any proper guidelines, but problem is very difficult to ask the patient to continue the same abemaciclib even the patient develops the same. For example, the 7% is, I think this thromboembolism is very tricky. I think we never seen that one, but here they said more than 7% with PTE or VT. But it's very difficult, but ultimately you can switch to another one or you can manage with like any other DVT with the cancer associated. Usually we'll start with some low molecular weight heparin for 1 month, then we can switch to weekly, low dose.
But in those patients who are on chemotherapy and if they develop DVTP, you don't stop the chemotherapy, right? You can give them anticoagulation, treat the DVT and continue the treatment under cover of anticoagulation.
Once the alternative is available, why do you want to ask continue the same thing? That's the problem. We can't, very difficult to convince the patient that.
Okay. All right. Any other comments or questions from the audience to the panelists with regards to the abstracts that we have discussed? Any burning issues that need to be discussed? So I think if there are none, I would conclude with my take-home messages. Obviously, in early breast cancer, individualization of therapy is required with respect to the choice of drugs and duration based on the clinico-pathological factors and genomic scores whenever feasible. I think the WSG ADAPT trial is a very interesting concept where response to preoperative endocrine therapy can guide treatment decision making. De-escalation again is a very interesting concept that needs to be explored, and probably the trials that will be done in the next few years will answer that question. Ovarian function suppression with the aromatase inhibitor should be preferred initial therapy for those patients who are high risk, that is grade 3, T2, and those who are less than 35 years of age. Extended duration hormone therapy should be considered in patients who are PT2 more than 2 centimeter, node positive, grade 3, and high Ki67 patients. Genomic scores should ideally be used whenever possible. I know in India we have that limitation, but whenever possible one should discuss this with the patient. Adjuvant abemaciclib should be discussed in patients with those who are more than 4 node positive or 1 to 3 nodes positive with either tumor size more than 5 centimeter, histologic grade 3 and Ki67 more than 20%. As far as advanced breast cancer is considered, CDK4 established have established themselves beyond doubt. They can be used in patients with extensive visceral disease also. So I think the important message here is that not necessary that every patient should be given chemotherapy. If the patient is really not in a visceral crisis requiring ventilator where you need an immediacy of response, probably in those group of patients one can try CDK4 inhibitors. I am more and more convinced that we need to monitor ESR1 mutations while the patients are on CDK4/6 inhibitor and an AI. And switching to an alternative CDK4 inhibitor appears to be a feasible treatment strategy as shown by the maintain trial. Both the AKT inhibition as shown by the faction trial and the Capitolo trial is a promising strategy, particularly those who have a pathway alteration in those group of patients. One should consider capivasertib. Obviously, access will be a big issue for us, but then again, we can apply for compassionate access or see if there are any trials that are ongoing. Again, FES PET-CT I think is a very important tool. Probably in future we will see more of it. That's what I feel. And obviously we need to find its right place in the armamentarium of our investigations. So with this, I think we will conclude this panel discussion.
Can I add one more? The emerging role of a PR positive ALDRED score of 7 or 8. Actually, at least I would not give so much of cognizance to PR receptor positivity.
Yes.
But this is from this year-end review, I found that, it was like orphan PR. Now, 7 or 8 ALDRED we should consider and the results are there. So,
yeah,
I'll add on to the take-home
yeah,
message.
so we know about it, I think, for a very long period of time that those who are positive, but probably we need to look at more carefully at the data to identify patients who would benefit with a one particular therapy. So I think with this, we'll conclude this panel discussion. Thank you very much.